Keratoconus is a word derived from Greek, kerato meaning horn and conus meaning cone, and is a bilateral non-inflammatory corneal ectasia. Corneal ectasias are a group of conditions of variable cause that result in progressive steepening or bulging, ectasia, of the cornea, resulting in a gradual deterioration of vision. The incidence of keratoconus is about 1 in 2,000, although less obvious forms of keratoconus, such as forme fruste, are thought to be more common. Keratoconus can affect people from all populations, but it tends to be more common in certain ethnic groups, such as South Asians, and in association with certain other conditions, such as atopy or Down syndrome. The pathophysiology of keratoconus is not well understood, but we know that in terms of genetics it's multifactorial. We also know that the disease runs in families, and certainly the genetic studies that have been done suggest an autosomal dominant mode of inheritance. Once the disease starts, we know that there is a gradual dissolution of Bowman's layer, which lies between the corneal epithelium and the underlying stroma. And as these two tissue layers come into contact, there is a loss of corneal integrity at both the structural and cellular level, resulting in the bulging and the scarring that is characteristic of the condition. Keratoconus classically presents in the teenage years, and again classically progresses to the 3rd or 4th decade of life, when there is either an arrest or a reduction in disease progression, although more recently progression in the over 50s has been increasingly recognized. Patients can complain of a variety of symptoms, including a blurring of vision, a problem with night vision and nighttime driving, photophobia, eye strain, and an inability to see things at all distances. If they present to the optician tends to detect a rapid deterioration in their vision associated with an increase in myopic astigmatism, and often this is asymmetrical, affecting one eye more than the other. As the disease progresses to an intermediate stage, vision is no longer correctable with soft contact lenses or spectacles, and in these instances, toric soft lenses can help with correcting some of the astigmatism. However, the increasing irregularity of the astigmatism may call for rigid gas-permeable contacts in order to achieve a truly crisp vision. Some patients are intolerant of these gas-permeable contact lenses and require a piggyback configuration consisting of a hard contact lens worn over soft lenses to achieve adequate fit, comfort and vision. However, these piggyback contact lenses are very difficult to fit and wear, and new mini-sclerals are so comfortable that these are usually the lenses of choice. On clinical examination, there are a number of signs that support the diagnosis of keratoconus, and these include Charlot's oil drop sign. If you observe the red reflex using a direct ophthalmoscope with a +6 lens dialed in, the cone shows itself up against the red reflex and gives the impression of an oil droplet in the way of the red reflex. We also have the scissor reflex as seen on retinoscopy. The retinoscopy reflex in this case will consist of two bands that either move away or towards each other, very much like the blades of a pair of scissors. Munson's sign consists of an indentation of the lower lid when you ask a patient with keratoconus to cast their gaze downwards. Fleischer rings are pigmented rings in the cornea, usually found at the base of the cone, and consist of iron in the form of hemosiderin, which is deposited in the basal layers of the epithelium. The rings are best observed by shining a blue light into the eye without the installation of fluorescein dye. Bogue striae are fine, white parallel lines that are found in the posterior stroma or in Descemet's membrane, and they may be asymmetrical depending on the degree of keratoconus in each eye. What we do know is that there is a correlation between the axis of these lines and the steepest axis of the cornea. Gentle external pressure on the globe can make these lines disappear. Finally, keratoconus can present more acutely in the form of corneal hydrops, where you get stromal edema secondary to aqueous leakage through a tear in Descemet's membrane. The patient typically presents with a triad of intense pain, a loss of vision and photophobia. There are different tiers of treatment for keratoconus. For patients whose vision can be adequately corrected by spectacles, then no other treatment is necessary. However, these patients should be told to never rub their eyes hard, since eye rubbing is known to be associated with keratoconic progression. In patients who have ocular allergies, they can be prescribed ocular lubricants or topical antihistamines in order to relieve their symptoms of ocular pruritus, thereby preventing them from rubbing their eyes and eyelids and thereby preventing keratoconic progression. When irregular astigmatism makes clear vision with spectacles impossible to achieve, then the next stage of treatment is the use of rigid gas-permeable contact lenses. The rigid gas-permeable contact lens essentially masks the irregularities of the underlying cornea and acts as the new refractive surface of the eye, with a tear film filling in the space behind the back of the contact lens and the front surface of the eye. However, in keratoconus, the steep cone and the irregular shape of the cornea makes the fitting of these lenses very challenging, and the success of this intervention is very much dependent upon the experience and the expertise of the contact lens fitter. If there is evidence of keratoconic progression, even in the presence of good vision, then it may be possible to perform a non-invasive corneal procedure known as collagen cross-linking. This utilizes ultraviolet light along with vitamin B2, otherwise known as riboflavin, which acts as a photosensitizer, and these work together to strengthen the chemical bonds that are already existent in the cornea. The goal of the treatment is to halt progressive and irregular changes in corneal shape and thereby preserve good visual acuity that can be managed by spectacles or contact lenses long-term for the patient. However, to be able to do this procedure, the cornea has to be at least 400 microns thick. An alternative method to try to restore some degree of vision is to use intrastromal corneal inserts. These are implanted in the deep corneal stroma to modify the corneal curvature to try to make it more regular. For keratoconus, these work by flattening the steep part of the cornea or cone to reduce visual distortions. The main indications for implantation of these rings are documented disease progression and contact lens intolerance. And again, the cornea should be at least 400 microns thick at the insertion site for implantation of these rings, and there should be a clear central cornea. If keratoconus progresses to the stage where contact lenses cannot be fitted, the patient cannot tolerate them, or the vision cannot be adequately corrected, then surgical intervention may be necessary, and this is usually in the form of a corneal transplant. Historically, about 1 in 5 keratoconic patients progress to the stage of surgery. The type of transplant that is performed, a penetrating keratoplasty or a full thickness transplant versus a deep anterior lamellar keratoplasty or a partial thickness transplant, is very much dependent on the residual thickness of the cornea and the presence of scarring. Penetrating keratoplasty, otherwise known as a PK, is a long-established surgical technique for the treatment of keratoconus, with the potential for a good visual acuity, and is a surgically less challenging technique. However, because of the replacement of host endothelium by donor endothelium, the risks of rejection with this procedure are quite high. Other problems associated with PK include a longer recovery time, greater post-operative astigmatism, and the loss of ocular integrity, although the latter is in part applicable to DULC also. Deep anterior lamellar keratoplasty, otherwise known as DULC, has been shown to be an excellent alternative to PK in keratoconic patients in whom there is no history of eye drops. DULC preserves the host endothelium and reduces immune system reaction and graft rejection. Other reported advantages include less risk of post-operative astigmatism, a faster visual acuity recovery time, and less severe surgical complications, although on practical levels this is not always the case. However, disadvantages of DULC include longer and more difficult surgery and a risk of perforation during surgery with slightly poorer visual acuity post-operatively. Unanswered questions include: how often should topography be done to detect progression, and does this change with age? Also, what is the least amount of change that can be used to document progression? And finally, in view of the highest risk of progression being in those under the age of 20, should they be offered cross-linking without looking for evidence of progression, as already occurs in Switzerland? So in conclusion, keratoconus is a very exciting area of development, and we look forward to seeing what the future holds in terms of new treatment modalities that can prevent the progression of this debilitating condition.